Hello, good evening, guys. Sorry, our session got a bit delayed. Yeah, yeah, guys. So, from anesthesia, 4 to 5 questions came, and all came from the LRR or the marathon marathon we did, right? First, you guys tell me how was the paper and how was anesthesia questions to you? Were the questions fine? I found it easy. Okay, so starting with the first question. Guys. Which of the following IV agents is commonly used for outpatient procedures? Guys, we have discussed this many times. Okay? Even though we might not have discussed like on the outpatient and all, but it's pretty obvious. Outpatient procedures, when it is asking, outpatient means what, guys? Daycare surgery. For daycare surgery, which is the IV induction agent of choice? So we are having propofol, thiopentone, ketamine, and ethomidate. So what's the answer? The answer for this is propofol. Again, going back to our marathon slide or the LRR slide, where I have already told you the IV induction agent of choice for daycare surgery. Propofol, you have to remember. You get propofol, as it is having a short elimination T-half of 2 hours or less than 2 hours. We use it for daycare surgery, and related to daycare surgery, many MCQs related to propofol I have taught you. It can be used for LMA insertion, it can be used for TIVA, and it's having anti-emetic, antipruritic property, malignant hypothermia, liver disorders, and for acute intermittent porphyria also we use propofol. Okay, coming to the next question, guys. What is the Mallampati score of this patient? Again, Mallampati. When a patient, Mallampati classification gives you the details of how easy the patient's airway is. By looking at the Mallampati, you can easily come to know that you can easily intubate or it is difficult to intubate. Okay? So, guys, when the patient is opening his mouth, I am able to see the hard palate, I am able to see the soft palate, I am able to see the whole of uvula, I am able to see the tonsillar pillars, yani ke I am able to see all the structures. Push. Class 1 is push. Okay? Push is nothing but tonsillar pillars, uvula, and soft palate and hard palate. So this patient belongs to which Mallampati class, guys? Mallampati class 1. Again, going back to our marathon slide or the LRR slide where we have discussed this. Okay? Mallampati class. It is class 1. Class 1 means what? You are seeing all the structures and you can easily intubate the patient. Okay? Next, guys. Identify the needle which is shown in the given image. Come on, guys. What is the needle which is being shown over here? What is the needle that is being shown over here? Again, we have discussed this many times. While discussing epidural anesthesia, I told you one needle will be there which will be having 1 centimeter of light and dark band on it. By looking at the needle, you will see that's an epidural needle that is used for giving epidural anesthesia. Okay. So, it is Tuhoy's epidural needle. It is Tuhoy's epidural needle, right? Tuhoy's epidural needle. Quinckeys and all, it's not there for spinal. Basically, this kind of needle, which will have 1 centimeter of dark and light band, this is commonly used for epidural anesthesia. Okay. So, we have discussed that needle also. Now, guys, coming to the next question. A COPD patient, right? A COPD patient is planned for abdominal surgery. What is the most effective measure to reduce the risk of post-operative pulmonary complications? Guys, again, we might not have discussed this as a direct question, but regarding the pre-anesthetic checkup, we have already discussed a few things. First of all, going back to the question, guys. COPD patient planned for abdominal surgery. Which is the most effective measure to reduce post-op pulmonary complication? Giving antibiotics. Guys, patient is not having any active infection. Why will you give an antibiotic? No. Unless and until active infection is there, no antibiotic is preferred. Okay? Wait for 3 months. But why do you wait for 3 months for COPD patient? Is the option saying you wait for 3 months and you are optimizing the patient? No, it is just saying wait for 3 months. No, waiting for 3 months does not reduce the risk of post-op pulmonary complications. Okay? Smoking cessation. Guys, remember, if a COPD patient is a smoker, it is not only a smoker, guys. Normally for elective surgeries also, if a patient is smoker, we advise them to quit smoking at least 4 to 6 weeks or 3 to 6 weeks before surgery. What happens, guys, if he quits smoking? If the COPD patient quits smoking, what will happen? The bronchial secretions will come down. The bronchial secretions will come down. The ciliary activity will be improved. The ciliary activity will be improved. And due to these things, bronchospasm risk and post-op pulmonary complication risk will be reduced. Oxygen therapy. Why will you give oxygen therapy? Oxygen therapy intraoperatively is needed, but again, it won't improve. Like any oxygen therapy given preoperatively won't improve the won't improve any the outcome. Okay, so remember, the most important thing over here is smoking cessation. So physiotherapy and smoking cessation. Yeah. Physiotherapy be able to, yes, physiotherapy also helps, right? Again, going back to our marathon slide, where I have told you what are the drugs which are stopped and what are the things which are stopped before surgery. I told you to remember, my clothes are usually stopped before surgery. My clothes, M stands for monoamine oxidase inhibitor, C stands for clopidogrel, L stands for lithium, O stands for oral hypoglycemic drug, T stands for tricyclic antidepressants, H stands for heparin, and S stands for smoking, right? Next, a patient is undergoing surgery with and shows a sudden drop in end-tidal carbon dioxide to 0. Okay, what does it most likely indicate? Okay, now going to the options, guys: hypothermia, hyperthermia, embolism, and hypotension. So what is the answer for it? Guys, remember, the answer for it based on the options which are given over here is what? Basically, remember, patient was undergoing surgery, and during surgery his EtCO2 was like this, 35 to 45. Okay? And suddenly what you saw is EtCO2 suddenly falling or becoming 0. Guys, remember, if EtCO2 is suddenly falling, the reason for it to suddenly fall is what, guys? Based on the answers, the options over here, it is always embolism. A massive air embolism leads to a sudden fall of EtCO2 of 0. But guys, remember, based on the options given over here, I've been giving this answer. But ideally, if you see in air embolism, venous air embolism also, it directly does not become 0. Slowly it will reduce. Normally in venous air embolism, what you will see is EtCO2 slowly it is reducing. But over the options over here, the best option is air embolism. If there is a massive embolism, yes, you will see EtCO2 of 0. Okay? Apart from embolism, what are the other causes where EtCO2 suddenly becomes 0? If there is any disconnection of the circuit, yani patient was intubated and you were ventilating and suddenly the circuit got disconnected, and you will see what? You will see an EtCO2 of 0, or you might see a sudden EtCO2 of 0 when a patient suddenly develops cardiac arrest during a case. During surgery, suddenly patient develops cardiac arrest, so he might develop a EtCO2 of 0. Okay? So this is regarding the sudden fall of EtCO2. So based upon the options, guys, the answer is over here, embolism. Okay? Acha, there was given a value of 15 to 5. Yani ki EtCO2 was gradually falling. Gradually falling means it is venous air embolism. Okay, guys? Is it clear? Again, going back to our LRR as well as marathon slide where I have taught you about EtCO2 sudden fall, right? You will see in this condition. Okay, so I guess, guys, all of the questions came from the notes and all, but again, me bragging it that all came from my notes, it doesn't matter. Okay, it basically, you guys have to tell me, was anesthesia helpful? Was the LRR, was the sessions helpful or not? Okay, I know you guys might be exhausted, but still, after watching the video and all, you can write in the chat box how was it and all, and you can also give me some suggestions how to improve in the next coming sessions, what to add, what more to add and all. Okay, anesthesia was easy. Okay, guys, all the very best. Now exam is done. Now you enjoy, okay? One liner. Sir, I have corrected all anesthesia questions. Sir, absolutely. Sir, proper answer. Remember, because of you. Thank you. Paper was tough to moderate. Okay, okay. Now, whatever was done, it is done. Okay, sit back and relax, guys. Okay. Okay. Thank you. Thank you very much. Thank you.